So after exploring the empirical evidence in favor of the diagnosis, what evidence is there for interventions and treatment of dissociative disorders? Before judging the evidence on psychological interventions in dissociative disorders, it's important to put this in perspective within the field of psychology as a whole. A 2010 extensive review by the Australian Psychological Society considered the evidence in support of psychological interventions for the entire spectrum of mental disorders in adults and children. The existing evidence was divided into 4 levels. Level 1 evidence meant there was a systematic review of randomized, controlled trials in favor of the intervention. Level 2 meant there was at least one properly designed randomized controlled trial. Level 3 represented comparative studies with varying levels of randomization and control, and Level 4 were either case series or post-test and pre- and post-tests. If held to the standard of drug treatments, only Levels 1 or 2 would be considered the equivalent to the levels of evidence that would be required typically to register a drug for a particular indication with a regulatory agency like the Food and Drug Administration. These are the various psychological interventions that were assessed in the review, some of which have also been used in treating dissociative disorders. And this summarized table shows the level of evidence that exists for these interventions, listed along the top, as employed in the treatment of various mental illnesses and disorders, listed along the left. Without getting lost in the details, the idea of the slide is merely to show that only Levels 1 and 2, which here are depicted as green and yellow blocks, would match the levels of evidence required for medication to be approved for a particular indication. So for dissociative disorders at the time of this 2010 review, only cognitive behavioral therapy had case series level evidence. What is important to point out, however, is the large number of black blocks. This means that the evidence was insufficient to meet any of the 4 levels of evidence in that particular application. So the entire field of psychology is relatively weak on this level of evidence, with the exception of those conditions that are relatively easy to measure and those treatments that can be blinded relatively easily and demonstrate fairly rapid responses. So, before providing the evidence that does exist for the treatment of dissociative disorders, it's necessary to know that the level of evidence for psychological and psychotherapeutic interventions as a whole is not particularly high. This is true for mental disorders in general, not only for dissociative disorders. Importantly, however, this apparent lack of evidence does not mean to say that there is a lack of research. Rather, what it does show is that the intrinsic, personal, relational nature of psychological and psychotherapeutic interventions does not lend itself as readily to those research methods which have become normative for instance, medication. By this I mean that it's much easier to do a prospective randomized placebo-controlled trial on medication than it is on the complex interpersonal dynamics of a psychotherapist and a client. And this is one of the reasons why it's so important for us to have reviewed the classifications of disorders in general, how diagnoses are made, how research is conducted, and why the nature of the scientific method itself favors the use of medication. Not because it is the most effective remedy necessarily, but because it is the easiest to study, the simplest to prescribe, and requires the least amount of patient cooperation. Rather than taking control of one's thought life and behaviors and making regular visits to a therapist, taking a pill every day requires very little effort, about the same as the commitment to brush your teeth, as long as costs, willingness to take it, and the opportunity to obtain medication are not significant barriers. Again, it is obvious that a default to medication is often more a matter of cost and practical convenience rather than being the most appropriate solution. So, given that the level of evidence for assessing the effectiveness of psychological treatment is relatively poor, what does the available evidence suggest? This 2009 review by Bethany Brand summarizes what was available at the time. various case studies and case series were examined in terms of the theoretical approaches to treatment and the type of outcomes that were recorded. They are listed here again for convenience, together with the authors and dates of their first appearance in peer-reviewed literature. Most of the original reports were only case reports. Their primary value does not lie in the strength of evidence they represent, or that the findings could be generalized, which they can't, but rather in the detailed description of how the modality was applied in the clinical setting of dissociative disorders, and what the outcome measures were that were used. These various psychotherapeutic modalities will be reviewed in turn. Psychopharmacology and hypnosis will be discussed a little later in the pharmacology section. Cognitive behavioral therapy. The strongest evidence is in supportive cognitive behavioral therapy, or CBT, for dissociative disorders. CBT is based on the work of Albert Ellis and Aaron Beck, amongst others. Beck's emphasis was on identifying internal beliefs and cognitive distortions. In other words, is the client's thinking about a particular issue adaptive or maladaptive? If it's maladaptive, it would seem reasonable that negative emotions would follow. The basic belief is that with any situation there will be corresponding thoughts. Those thoughts will lead to feelings and eventually to actions. So a key concept of this reasoning is that the underlying belief is that people can make choices about what they think. In DID, the cognitive approach is very empowering because it helps clients to recognize that they do have choices about how they react to events. CBT therapists intervene by helping clients become aware of cognitive distortions and how to create more adaptive thoughts. The therapists use questioning in such a way as to disprove the client's faulty logic. This can help them see how their own negative thoughts are affecting their lives. Rational emotive therapy is a derivative of CBT and also addresses rational versus irrational ways of thinking. The so-called ABC-D model involves A, for the activating event, B, for clients' beliefs about the event, C, the consequences of those beliefs, and finally, D, disputing the irrational beliefs. The premise behind this therapy is that people are not disturbed primarily about what happens to them, but rather why it happened. In other words, their beliefs about the events in their lives. This is the first reported use of CBT for multiple personality disorder, published by Caddy in 1985. It records a detailed analysis of emotions and behaviors of each subpersonality in a single patient with corresponding CBT strategies leading to ultimate integration. Psychodynamic therapy. The theory behind psychodynamic therapy arose from the original work of Sigmund Freud. It is probably the most widely used approach in DID. Psychodynamic therapy acknowledges the influence of the unconscious on behavior and places major importance on the function of the ego, the self, and social relationships. This theory places more emphasis on early childhood than most other approaches do. It assumes we have an internal world affected by the past, which in turn affects the present. It proposes that we carry internal representations of both ourselves and others, and that these representations profoundly affect our interactions with the world. According to this theory, the development of an integrated self begins in childhood. As such, a fragmented sense of self develops by our needs not being met in early childhood. When that happens, a child learns to split off the unacceptable parts of the self. One belief associated with this theory is that we all possess both good and bad impulses, and that it is the ability to integrate the two that is a sign of health. The concept is important for people who dissociate to banish unacceptable aspects of themselves from consciousness. During treatment, the therapist listens to the client's story, mirrors back the experiences, and offers interpretations from which the client can eventually derive insight on their own. To address the issues of childhood abuse and to re-establish a sense of self takes time. The concept of transference and countertransference relationships and therapy are essential to this approach. Transference refers to the client's response to the therapist and to others, based on early life experiences, whereas countertransference refers to the therapist's response to the client, based on the therapist's life experiences. In short, psychodynamic therapy interprets what the client shares, assists the client in working through the transference relationship, and brings disowned parts of the self into awareness. This paper presents the outcome of psychodynamic therapy in the treatment of 3 individuals presenting with obsessive-compulsive spectrum disorders in association with histories of early childhood trauma and dissociation features. It illustrates that the interpretation of troublesome behavior in the light of repressed childhood memories can be important in achieving resolution. Phenomenological treatment. In the words of Carl Elleman, who pioneered the application of this method in DID, phenomenological treatment of dissociative identity disorder involves the following. Firstly, the demystification of the dissociation. Secondly, the breakdown of amnestic barriers. And thirdly, the integration of alter conscious states. While standard treatment presupposes an understanding of the adaptive role of dissociation in mitigating childhood trauma, phenomenological methods entail a suspension of judgments about the patient's historical existence and bracketing the clinical theory, as well as cultivating a neutral as-if point of departure. As detailed in his paper, Elleman de-emphasizes the importance of pursuing the specific details or accuracy of the abuse history. Rather, the therapist remains non-judgmental, in a state of suspended belief, and then collaborates with the client to identify the various personalities and their respective roles, like actors in a screenplay, and then showing the individual that they are all part of the same person. The capture of the characters is called bracketing. The technique does not require recollections of past trauma, nor on understanding or convincing the client about any particular theory of mind. Instead, somewhat metaphorically speaking, it invites the DID alters, like actors, to gradually work through the script, until they all either join or at least take cooperative hands like actors would do before an appreciative audience at the end, which in this case is represented by the therapist. Contextual therapy. Contextual therapy, pioneered by Dr. Stephen Gold, attempts to address the deficits in interpersonal and social skills that clients have due to growing up essentially alone, without the consistent emotional support and guidance needed for development of effective functioning. It tries to avoid the situation in which the trauma events themselves in isolation obscure these deficits, and it represents itself essentially as an alternative to trauma-focused treatment. It follows a psychotherapeutic approach that emphasizes helping survivors develop the capacities for effective functioning which were never transmitted to them during their formative years. This is the original peer-reviewed publication using the contextual approach in a case study of 3 women. Dr. Gold's book, shown on the previous slide, provides detailed descriptions of the methods and interventions that make up contextual therapy. Cognitive analytical therapy. Cognitive analytical therapy, or CAT, is a form of psychotherapy initially developed in the context of the United Kingdom's National Health Service by Anthony Ryle. This time-limited approach to therapy attempted to offer effective, affordable, realistic psychological treatment within the resource-constrained public health service. It is distinctive in its intensive use of reformulation, its integration of cognitive and analytic practice, and its collaborative nature, in terms of very actively involving the patient in their treatment. Practitioners work with the patient to identify procedural sequences, chains of events, thoughts, emotions, and motivations that explain how a target problem, for example self-harm, is established and maintained. In this first case report by Kellett, the application of CAT for DID is documented, showing several areas of prompt improvement. Feminist therapy. Feminist therapy as a whole has arisen in response to the disparity between the masculine origins of most psychological theories and the predominant recipients of psychotherapy being female. It focuses on societal, cultural, and political gender-associated issues and solutions, and openly encourages the client to participate in the world in a more social and political way. Feminist therapy contends that women are in a disadvantaged position in the world. It argues that many problems in therapy are due to disempowering social forces. The goal of therapy is therefore to recognize these forces and empower the client accordingly. In a feminist therapy setting, the therapist and the client work as equals. The therapist must demystify therapy from the beginning to show the client that she is her own rescuer, and the expectations, roles, and responsibilities for both client and therapist must be explored and equally agreed upon. The therapist recognizes that for every symptom the client has, there is a strength. This paper evaluates the treatment of DID patients in an all-women's inpatient milieu using Baker-Miller's relational model of women's psychological development. The feminist perspective addresses the gender inequalities in that, demographically, female-to-male ratio in DID is reported as 9:1 according to Putnam. Secondly, abuse occurs within the context in which there is an unequal balance of power between the abuser and the victim. Thirdly, that DID is primarily a disorder involving the detachment of the self, resulting in a lack of relatedness between the parts and the whole self, as well as between the self and others in the external environment. And 4, Miller's relational model specifically addresses the role of connections and disconnections in the development of a woman's healthy sense of self within the context of relationships with others. Many DID patients engage in self-inflicted violence due to having an enduring sense of themselves as being either deserving of harm or even asking for it. This approach, based on equality, addresses the issue from a self-worth paradigm. EMDR, or eye movement desensitization and reprocessing. EMDR therapy is not one of the modalities included in the Australian review, but they acknowledge the omission and confirm the increasing body of evidence supporting its potential role in psychotherapy. EMDR is far more than guided eye movements. It is an integrative psychotherapy approach that has been extensively researched and applied for the treatment of trauma. It is made up of a set of standardized protocols that incorporate elements from many different treatment approaches. This is the first paper reporting the outcome of 2 DID patients with persistent phobias using EMDR. Improvements were evident after a single session. However, the researchers issue a cautionary note that their findings cannot be generalized without further research. Having reviewed some of the possible psychotherapy approaches for which there is published evidence of potential benefit, it is important to restate that, irrespective of the theoretical foundations or the format in which therapy is provided, the phase-oriented approach remains the recommended overarching schema for treating dissociative disorders. This phase-oriented model was first proposed by Pierre Janet in 1889. It prioritizes and orders the main clinical outcome objectives during the course of therapy. Stage 1 focuses on safety, stabilization, and symptom reduction. Stage 2 visits trauma memories gradually and for the purpose of removing amnestic barriers to access fragmented and sequestered parts of the self. Whereas Stage 3 focuses on identity integration, or at least functional collaboration between altered parts, and moves towards the final lifelong psychological rehabilitation process of attaining optimal, independent functioning in society and in the workplace. So, to conclude this section on psychotherapy, in spite of many challenges in conducting research in this area, a review of existing research over especially the past 30 years, including various case studies and case series, cost-efficacy studies, naturalistic outcome studies, which means looking at what happens without intervention, and follow-ups following interventions, which are now as long as 10 years, there is clinical justification and some scientific support for using appropriate psychotherapy within a phasic approach to trauma, and that it is able to lower the associated clinical disorders, positively impact personality disorder traits, reduce suicidality, and lower substance abuse, and that these improvements are sustained. It is also recommended that individuals with dissociative disorders receive the following core interventions throughout. Continuing psychoeducation, which means that they should be offered information to give them greater insight regarding the dissociative disorder. Increased awareness of and improved ability to tolerate and manage their emotions constructively. Improved ability to control impulses. To foster the skills that will allow them to remain grounded in reality rather than relying on psychological escape through dissociation. To nurture the therapeutic alliance and to manage stresses within their current relationships and the activities of daily living. When this is done, treatment outcomes show that, firstly, when patients were enrolled at a younger age, their destructive and suicidal behaviors stabilized more rapidly than for older patients, which emphasizes the importance of detecting these conditions as early as possible. And secondly, that those who improved suddenly were subject to fewer re-victimizations and stresses compared to those who worsened, thereby emphasizing the importance of safety and stabilization as part of the prerequisites for success. So to conclude this section on diagnosis and psychotherapy, the empirical literature on DID emerging over the past 30 years shows that beyond the rhetoric and controversy, DID is a valid disorder characterized by amnesia, identity confusion, and the coexistence of dissociative identities. It can be differentiated from other psychiatric disorders as well as from feigned presentations of DID. The characteristic features include a complex array of coexisting symptoms associated with psychosis, mood, anxiety, affect regulation, and personality functioning. It is a mix of subtle and overt developmental, interpersonal, and cultural drivers that produce DID, with childhood attachment-based trauma appearing to be a universal factor, while social idioms of self produce components of cultural specificity. DID is found around the globe in almost every culture in which researchers have carefully assessed for the range of dissociative symptoms. Research on dissociative identity disorders is proceeding and advancing, providing fascinating insights into the power of the mind to cope with developmental trauma and severe attachment disruptions in the cultural contexts in which they occur. They are not without controversy. However, the goals are not to label, but to liberate. The emphasis is not on the damage or disability. It is on the amazing mental resources which once allowed these individuals to survive as children, but now need to be reoriented for them to thrive as adults.